The cornea is a crucial part of the eye, acting as one of its main refractive media. Its transparency is essential for clear vision and is maintained by a unique arrangement of anatomical structures and the absence of blood vessels. This transparency relies on a special dehydration mechanism, primarily managed by the corneal endothelium and, to a lesser extent, the epithelium. Excess water is drained into the aqueous humor, keeping the cornea optimally hydrated. When this balance is disrupted, fluid accumulates, leading to corneal edema. Understanding the cornea's structure and function sets the stage for exploring its diseases. Diseases of the cornea are clinically significant, often leading to permanent opacities and complications that can result in partial or total blindness. These diseases are broadly classified into inflammatory and non-inflammatory types. Inflammatory conditions include keratitis, which can be superficial or deep and may be purulent or non-purulent. Non-inflammatory diseases encompass degenerative conditions like arcus senilis, corneal dystrophies, ectatic conditions such as keratoconus and keratoglobus, and symptomatic issues like corneal edema and ulcers. This classification helps guide diagnosis and treatment strategies. Corneal edema occurs when fluid enters the corneal tissue due to dysfunction of the epithelium or endothelium. This excess fluid disrupts the cornea's transparency, causing haziness and swelling. The condition can arise from various causes, including trauma, inflammation, or degenerative changes. Symptoms include blurred vision, irritation, and sometimes pain. Treatment focuses on addressing the underlying cause, using concentrated saline solutions, and, in severe cases, surgical interventions like keratoplasty. Understanding corneal edema is vital for recognizing early signs and preventing vision loss. Keratitis refers to inflammation of the cornea, characterized by corneal edema, cellular infiltration, and conjunctival congestion. Because the cornea lacks blood vessels, most inflammations are caused by exogenous infections or local spread from adjacent ocular tissues. Exogenous infections involve bacteria or fungi entering the cornea, often following trauma. Local spread occurs from diseases of the conjunctiva, sclera, or uveal tract. Rarely, endogenous infections arise, typically allergic in nature, such as interstitial keratitis due to hypersensitivity to Treponema pallidum antigens. Keratitis is classified into superficial and deep types. Superficial keratitis can be ulcerative or non-ulcerative, with further subdivisions into purulent and non-purulent forms. Purulent keratitis includes ordinary pyogenic corneal ulcers, hypopyon ulcers, mycotic ulcers, marginal ulcers, and ulcers associated with smallpox. Non-purulent types involve ulcers linked to trachoma, dendritic ulcers, leg ophthalmic ulcers, ulcers from vitamin A deficiency, neurotropic ulcers, allergic ulcers, degenerative ulcers, and superficial punctata keratitis. Deep keratitis, often allergic, includes interstitial keratitis, disciform keratitis, intracorneal abscesses, and sclerosing keratitis. Purulent keratitis is typically caused by exogenous pyogenic organisms. Some bacteria, like gonococci and diphtheritic organisms, can invade intact corneal epithelium, while others require epithelial damage. Trauma, poor corneal resistance, nutritional deficiencies, epithelial desquamation, neuroparalytic keratitis, and dry cornea are predisposing factors. The pathology progresses through stages. Initial inflammation causes polymorphonuclear infiltration and ulceration, followed by regressive healing with smooth, transparent ulcer edges, and finally cicatrization, where fibrous tissue fills the ulcer, leading to permanent opacity. Corneal ulcers present with pain due to nerve exposure, lacrimation, photophobia, headache, and blurred vision from corneal haziness. Signs include marked blepharospasm, especially in children, rough yellowish-white areas on the cornea, loss of window reflex, corneal haziness, ciliary congestion, muddy iris, constricted pupil, and possible hypopyon. Corneal vascularization may also occur. Diagnosis is aided by fluorescein staining and clinical examination. Recognizing these symptoms and signs is crucial for early intervention and preventing complications. If untreated, corneal ulcers can deepen, causing thinning and bulging ectasia of the cornea. Severe cases may lead to perforation, iris prolapse, panophthalmitis, and phthisis bulbi. Other complications include corneal opacity, iridocyclitis, secondary glaucoma, ectatic cicatrix, adherent leukoma, anterior staphyloma, anterior polar cataract, subluxation of the lens, expulsive hemorrhage, and complete vision loss. Timely management is essential to prevent these serious outcomes. Treating corneal ulcers involves controlling infection, maintaining cleanliness, ensuring rest, and protecting the eye from harmful external factors. Cauterization of spreading ulcers and the use of steroids after healing are important steps. General health care is also emphasized. The approach varies depending on whether the ulcer is perforated or not, with specific interventions tailored to the ulcer's size and location. For imperforated ulcers, treatment focuses on addressing the underlying cause and preventing predisposing factors such as conjunctivitis, dacryocystitis, foreign bodies, and nutritional deficiencies. Atropine eye drops provide rest by paralyzing the ciliary muscle. Hot fomentation encourages repair, and irrigation with saline removes necrotic material. Broad-spectrum antibiotics are used until culture results are available, with additional antiviral or antifungal drugs for specific infections. Steroids are reserved for post-healing to avoid inhibiting repair. Surgical interventions for corneal ulcers include cauterization of non-healing margins, paracentesis to drain accumulated aqueous, conjunctival flap grafts for persistent ulcers, and tarsorrhaphy for neuroparalytic or exposure keratitis. These procedures aim to restore corneal integrity, prevent further complications, and improve healing outcomes. The choice of surgery depends on the ulcer's severity and response to medical treatment. Management of perforated corneal ulcers depends on the ulcer's size and location. Small perforations in the pupillary area pose little risk of iris prolapse and are treated with firm pad and bandage, avoiding forceful actions like nose blowing or coughing. Peripheral perforations may lead to adherent leukoma and follow similar treatment. Corneal fistulas require full-thickness keratoplasty. Prompt and appropriate intervention is crucial to prevent further complications. Corneal ulcers come in various forms, including suppurative keratitis, hypopyon ulcers, mycotic ulcers, marginal ulcers, ulcers associated with smallpox and trachoma, dendritic ulcers, lagophthalmic ulcers, neurotrophic ulcers, flectennular ulcers, atheromatous ulcers, and Morin's ulcers. Each type has distinct etiologies, clinical presentations, and treatment approaches. Recognizing the variety helps in accurate diagnosis and tailored management. A hypopyon ulcer is a corneal ulcer associated with inflammatory exudate in the anterior chamber, often due to iridocyclitis. Causes include bacterial infections like Pseudomonas and Pneumococcus, fungal infections such as Aspergillus and Candida, and viral infections from measles or smallpox. Clinical signs are intensified, with slough on the ulcer floor, more infiltration, fluid or thick hypopyon, corneal abscess, and Descemet's folds. The hypopyon remains sterile unless the ulcer perforates, and its absorption is possible if inflammation is controlled. Treatment for hypopyon ulcers mirrors that of imperforated corneal ulcers, with added emphasis on antifungal and antiviral drugs for fungal and viral infections. Paracentesis may be performed to remove thick hypopyon, and dacryocystoreinostomy or dacryocystectomy is recommended to eliminate septic focus. Early and aggressive management is vital to prevent complications and preserve vision. Mycotic ulcers are caused by fungi like Aspergillus and Candida, often following agricultural injuries. Symptoms include mild pain, irritation, watering, and a yellow patch on the cornea. Signs are a yellowish-white, dry-looking ulcer with dry slough and thick hypopyon. These ulcers respond poorly to antibiotics, requiring routine ulcer treatment, scraping for drug penetration, and prolonged use of antifungal drugs such as natamycin, miconazole, nystatin, amfotericin B, and pimafucine. Systemic antifungals may also be needed. Steroids are contraindicated as they worsen fungal infections. When mycotic ulcers do not respond to medical therapy, surgical options are considered. These include cauterization, conjunctival grafts, and full-thickness keratoplasty. Surgery aims to remove infected tissue, promote healing, and restore corneal function. The choice of procedure depends on the ulcer's severity and response to antifungal treatment. Dendritic ulcers are a special type of non-purulent superficial keratitis caused by herpes simplex virus, commonly affecting children and young adults. Symptoms include severe irritation, lacrimation, and blepharospasm. Vesicles may appear on lips, nose, and genitals. Slit lamp examination reveals dot-like superficial infiltration with lateral branches forming a dendritic pattern. Small vesicles on the cornea rupture, leading to ulcer formation. Corneal sensitivity is reduced, and vascularization is absent. Recurrence and complications like disiform, keratitis, and hypopyon are possible. Early treatment of dendritic ulcers involves atropine, hot compress, and bandage for relief. If the ulcer spreads, cauterization may be necessary. Topical antiviral drugs such as 5-ido-2-deoxyuridine, adenine arabinoside, acyclovir, acycloguanosine with ARA, and trifluorothymidine are used. High doses of vitamin C and A support healing. Lamellar keratoplasty is considered for recurrent cases. Prompt and appropriate therapy helps prevent complications and recurrence. Herpes zoster ophthalmicus is a non-ulcerative, non-purulent condition caused by the varicella zoster virus, related to chickenpox. It typically affects one side of the face, targeting the Gasserian ganglion and branches of the ophthalmic division of the fifth cranial nerve. Symptoms include sudden fever, malaise, severe neuralgic pain, and vesicular rashes. Skin lesions may suppurate, bleed, and leave permanent scars. Ocular manifestations include superficial punctate keratitis, iridocyclitis, corneal insensitivity, gray scarred sclera, and iris atrophy. Paralysis of cranial nerves may occur. Treatment for herpes zoster ophthalmicus is mainly symptomatic. Analgesics relieve pain. Hot fermentation soothes discomfort, and skin lesions are managed with zinc calamine lotion, antiviral creams, or steroid antibiotic combinations. Topical therapy includes atropine, acyclovir, broad-spectrum antibiotics with steroids, and artificial tear drops for exposure keratitis. Systemic acyclovir is started promptly, and steroids are used for nerve paralysis or optic neuritis. Full-thickness keratoplasty may be required in severe cases. Iris prolapse occurs when the cornea is perforated by trauma, ulcer, or as a complication of intraocular surgery. There are two main types: hemispherical prolapse, which does not include the pupillary margin, and total iris prolapse, where most of the cornea sloughs off except a narrow rim. Soon after prolapse, gray or yellowish exudation appears on the iris surface. Prompt surgical intervention is essential to prevent further complications. Small iris prolapses may be replaced with an iris repositor or require peripheral buttonhole iridectomy under anesthesia. Large prolapses necessitate sector iridectomy, excising the iris up to the pupillary margin. Preventive measures during intraocular surgery include peripheral iridectomy, good suturing, and injection of balanced salt solution. Avoiding eye rubbing, straining, and coughing reduces the risk of iris prolapse. Decimetocele, also known as keratocele, occurs when a corneal ulcer reaches Decimet's membrane. This elastic membrane initially resists herniation, but eventually forms a transparent vesicle due to intraocular pressure. The decimetocele may persist, surrounded by a white cicatricial ring, or rupture if pressure increases. Treatment involves paracentesis and protective measures to prevent perforation and further complications. Corneal vascularization, or pannus, can be superficial or deep. Superficial vascularization arises from conjunctival vessels near the limbus, appearing irregular and tortuous beneath the epithelium. Deep vascularization involves straight, regularly arranged vessels beneath Bowman's membrane, not continuous with conjunctival vessels. Vascularization helps restore lost tissue and supplies antibodies during healing. Ghost vessels may persist after healing. Corneal dystrophies are progressive weakening disorders of the cornea. Endothelial dystrophy of features involves degeneration and opacity, typically in elderly females. Hereditary dystrophies, such as granular, macular, or nodular types, cause central corneal opacities and usually affect males at puberty. These conditions are bilateral and may significantly impair vision. Early detection and management are key to preserving sight. Ectatic conditions of the cornea may be congenital or post-inflammatory. Keratoconus, a conical cornea, results from bilateral congenital weakness, often in girls at puberty, causing progressive myopia and visual impairment. Keratoglobus, or megalocornea, involves hemispherical protrusion and increased corneal diameter, usually seen in males. Differential diagnosis includes ophthalmos, where cornea remains clear with normal anterior chamber and intraocular pressure. Corneal oedema is common and results from glaucoma, uveal inflammation, degeneration, or trauma to the endothelium. Fluid accumulates, causing steamy epithelium, increased thickness, and haziness. Striate keratitis may develop, and long-standing edema leads to vesicle formation and irritation. Treatment is often unrewarding, focusing on eliminating the primary cause, using concentrated saline or sodium chloride ointment, and surgical options like conjunctival transplantation or keratoplasty. Corneal opacity is the loss of transparency, caused by inflammation, ulceration, or trauma. Types include nebular faint, cloud-like, macular dense, gray spot, and leukoma dense, white scar. Symptoms depend on the opacity's location. Central opacities obstructing the pupil cause visual loss. Changes may include disappearance in infants, pigmentation, reduced sensitivity, and atheromatous ulcer formation. Treatment for corneal opacity depends on severity. Leukoma obstructing the pupil requires optical iridectomy, preferably in the inferior nasal quadrant. Severe vision loss from large leukoma is managed with keratoplasty or corneal transplantation. Lamellar keratoplasty is used for superficial scarring. Cosmetic coloring or staining of the cornea is performed for disfigurement using gold chloride, platinum chloride, or tannic acid. Contraindications include irritable eyes, and complications may involve cyclitis. The uveal tract consists of the iris, ciliary body, and choroid, forming the anterior and posterior uvea. It is highly vascular and responsible for antibody formation, making most affections allergic in nature. The ciliary processes secrete aqueous humor, providing nutrition to the lens and cornea. Understanding the uveal tract's anatomy and function is essential for diagnosing and managing its diseases. Infections can reach the uveal tract through exogenous routes, perforation of cornea, local spread from adjacent tissues, or endogenous routes via the bloodstream. Bacterial, viral, and protozoal organisms are implicated. Exogenous infections cause acute purulent iridocyclitis and panophthalmitis, while endogenous infections, termed granulomatous uveitis, result from systemic diseases. Allergic or hypersensitive reactions also occur, leading to non-granulomatous uveitis. Anterior uveitis, or iridocyclitis, involves inflammation of the iris and ciliary body. Pathology includes congestion of blood vessels, exudation of fibrin-rich fluid, and accumulation of inflammatory cells. The type of cells vary. Polymorphonuclear in exogenous infection, lymphocytes in allergic uveitis, and mononuclear in granulomatous uveitis. Fluid accumulation causes oedema, muddy iris, sluggish pupil, and sticky endothelium. Keratic precipitates and hypopyon may form, leading to Synechiae and secondary glaucoma if untreated. Iridocyclitis presents with severe neuralgic pain radiating along the fifth cranial nerve, worst at night. Other symptoms include lacrimation, photophobia, ciliary congestion, and blurred vision from plasmoid aqueous and exudation. Signs are purple-red hyperemia around the limbus, hazy anterior chamber, constricted and irregular pupil, muddy iris, pigmentary ectropion, iris nodules, synechiae, and vitreous opacities. Recognizing these features aids in prompt diagnosis and management. Iridocyclitis can lead to secondary glaucoma, complicated cataract, retinal complications like cystoid macular edema and detachment, and phthisis bulbi. Secondary glaucoma arises from exudates blocking the chamber angle, ring synechiae, occlusio pupillae, and cyclitic membrane formation. Complicated cataracts develop rapidly if posterior synechiae is present. Retinal complications are prevented by prompt steroid use, and phthisis bulbi results in complete vision loss. Differentiating iridocyclitis from conjunctivitis and acute congestive glaucoma is essential. Conjunctivitis has gradual onset, mild discomfort, mucopurulent secretion, superficial congestion, and normal cornea. Iridocyclitis presents with moderate pain, watery secretion, deep ciliary congestion, normal or opaque cornea, constricted pupil, and slightly impaired vision. Acute glaucoma has sudden onset, severe pain, deep congestion, steamy insensitive cornea, shallow anterior chamber, dilated oval pupil, markedly raised intraocular pressure, and severe vision loss. Investigations for uveitis include total and differential leukocyte counts, ESR, blood sugar, uric acid, plasma proteins, throat swab culture, VDRL, tuberculin test, anti-nuclear antibodies, Rh factor, urine and stool cultures, chest and spine X-rays. These tests help identify underlying systemic diseases like rheumatoid arthritis, spondylitis, and autoimmune conditions, guiding appropriate treatment and preventing recurrence. Treatment of uveitis aims to relieve pain, identify and treat underlying causes, and prevent vision-threatening complications. Atropine sulfate provides rest by paralyzing the ciliary muscle, dilates the pupil, and enhances antibody delivery. Heat application reduces pain and increases circulation. Corticosteroids control inflammation, used as drops, ointment, or injections. Analgesics and anti-inflammatories address discomfort, and antibiotics prevent secondary infection. Treating systemic diseases is crucial for recurrence prevention. Complications like secondary glaucoma, complicated cataract, retinal detachment, and phthisis bulbi require specific interventions. Secondary glaucoma is managed with timolol eye drops and acetazolamide tablets, with iridectomy or laser iridotomy for ring synechiae. Cataract extraction is performed after controlling acute inflammation. Retinal complications are prevented with steroids and vitrectomy for detachment, Painful phthisis bulbi may necessitate enucleation. Posterior uveitis, or choroiditis, involves inflammation of the choroid and outer retina. Clinical forms include granulomatous choroiditis from pathogenic infections like syphilis or tuberculosis, and exudative choroiditis from allergic reactions. Symptoms are defective vision, metamorphopsia, micropsia, macropsia, photopsia, and scotomas. Signs include ill-defined yellowish areas, vitreous opacities, and sharply defined fibrous patches. Treatment is often unsatisfactory due to late detection, with anterior uveitis therapy applied. Choroiditis symptoms include defective vision from retinal lesions and vitreous haziness, metamorphopsia, wavy lines, micropsia, objects appear smaller, macropsia, objects appear larger, photopsia, flashes of light, and positive scotoma, black spot in vision. Negative scotoma affects peripheral vision, limiting fine activities. Recognizing these symptoms is key to early diagnosis and intervention. Signs of choroiditis include ill-defined yellowish areas beneath retinal vessels, punctate or diffuse vitreous opacities, and white fibrous tissue surrounded by black pigment. Classification is based on lesion number and location: localized, central, juxtapapillary, peripheral or diffused, disseminated throughout the fundus. Diffused choroiditis always involves the anterior uvea. Accurate classification guides treatment and prognosis. Panophthalmitis is a severe, purulent inflammation of all eye structures, including Tennant's capsule, leading to vision loss by fibrosis, atrophy, or globe rupture. Etiology includes exogenous entry of pathogens via corneal perforation and endogenous septic emboli. Pathology involves infiltration of the uveal tract with polymorphonuclear cells. Symptoms are severe pain, headache, fever, vomiting, vision loss, lacrimation, and purulent discharge. Signs include red, swollen lids, intense congestion, hypopyon, hazy cornea, yellow reflex, proptosis, and limited eye movement. Treatment of panophthalmitis involves broad-spectrum antibiotics by all routes to achieve high intraocular concentration, including eye drops, ointment, subconjunctival injections, and systemic therapy. Sodium fusidate and gentamicin are effective. Corticosteroids are used topically, by injection, and systemically to control inflammation. Atropine provides rest, and early vitrectomy with intravitreal antibiotics may preserve vision. If infection persists, evisceration is performed to prevent meningitis. Endophthalmitis is acute inflammation of the posterior segment, affecting the choroid, retina, and vitreous, often leading to atrophy. Etiology includes exogenous injury, endogenous bacterial embolism, and complications of intraocular surgery. Pathology shows lymphocyte infiltration and cyclitic membrane formation, causing retinal separation. Symptoms are pain, lacrimation, photophobia, Keratic Precipitates, leukocoria, hazy vitreous, white pupillary reflection, low intraocular pressure, and eventual phthisis bulbi. Investigations include culture and sensitivity tests of aqueous and vitreous.